mostly it's all bad. One of the epidemic of methamphetamine-induced psychosis is, it's just amazing how it's gotten worse practically every year over the past 20 years. But certainly, Los Angeles has become much more of a meth capital than a cocaine capital. On the East Coast, you might see more cocaine-related psychosis. Both stimulants, a little different. Hallucinogens are tricky. There are certain situations where people will say the expanded consciousness has induced creativity under supervised settings. But if you are vulnerable to psychosis, I would stay away from it for sure. The mixed bag right now is cannabis. And there are people who swear it's really helped them, and others, again, right now, well-documented epidemic of psychosis triggered by cannabis use, because this is not your grandfather's cannabis that's out there. It's so much more potent. It's like comparing, between what cannabis was in the 70s and now, it's like comparing a beer to a quart of vodka. It's not the same thing. And what we know now is that, especially through critical development periods between onset of adolescence around 13 to the age of 25, when the prefrontal cortex is completely myelinated, during that period, regular cannabis use increases your risk of developing schizophrenia fourfold. It also, one New Zealand study showed that during that period of time, it drops your IQ an average of 7 points, and it doesn't come back. So after the age of 25, those effects tend to dissipate, but it's still not necessarily benign. On the other hand, there are some studies that have come out on CBD, cannabidiol, which is one of the cannabinoids. There's one study that was a well-designed study out of Europe that came out last year that compared patients who had schizophrenia on an antipsychotic. Half got an active placebo, so I think they were given Benadryl, and the other half got CBD, and the CBD group had much better control of their symptoms than the active placebo. And there have been smaller demonstration studies, one that was done at UC Irvine, a few others that also supported that. So there may be a role of purified CBD, but in the marketplace, if you're getting CBD, it's often contaminated with THC. And the regulating, and we're far from truly regulating, but regulating cannabis with the legalization has helped a bit, because there's an enormous amount of contaminants in randomly tested cannabinoids. Something like 40% of cannabis doesn't pass testing to be able to be sold legally. But in my mind, it's I've seen it mostly do more harm than good in the population of people I treat. But I have seen also some people who've had positive results, so mostly anecdotal. I had one patient, she was 70 years old at the time I treated her, lifelong depression, very successful, had a Harvard MBA, was a retired hotel executive, never been free of depressive symptoms her entire life. She had kind of an abusive childhood. We tried all kinds of antidepressants, and I was seeing her weekly in therapy. And one day a friend told her, well, you should try cannabis. And she'd never tried cannabis, 70 years old. They gave her some edibles. So she took one, didn't feel anything in a few minutes, so took another. So took another, didn't feel anything. Took another, took a whole handful, saying, this is not doing anything. And then she went into a cannabis overdose. And she was so sick and vomiting, but she was too embarrassed to go to the emergency room. So she just stuck it out and was like, could hardly walk for 2 days. And when she came out of it, her depression was gone. This is now 2 years later, and she's still not depressed. She's still on her antidepressant.
Oh my God.
But it's the weirdest thing. I thought about writing this case up. She's now got a boyfriend who's a retired anesthesiologist. sociologist, she's traveling. Said, I feel great. So I don't recommend you try that at home. But a weird case.
Very strange.
We also have a session on mental illness and marijuana in the afternoon. How is borderline personality being treated currently?
So borderline personality disorder. So, it's interesting. The colleagues of mine that run the institution have the CEO, the founder, who opened up a program on the west side that was for much higher functioning people. Before we opened up our Pasadena, really it's argued that borderline personality disorder often has a lot of negative associations with it. It's one of the least easy to validate and have greater validity. And it's almost always associated with traumatic childhood, either through neglect or abuse. Not always, and that many of those people later develop post-traumatic stress disorder or may have a dissociative disorder. So we call it complex trauma. Nonetheless, the evidence-based treatment that seems to be most helpful is dialectical behavioral therapy. Really teaches a lot of things like distress tolerance, mindfulness, and really develop skills on how to interact with others better. One of the things that's interesting in terms of functional neuroimaging, when you look at, well, first of all, if you get someone who people mutually agree have borderline personality disorder, there's a test where that you can look at these standardized pictures of faces that uniformly reflect a certain affect. And people with borderline personality disorder are much more likely to see a neutral face with no affect at all as angry. And their amygdala, which is the part of the limbic system that picks up, that sort of the center of the beginning of the stress response, is much more overactive in these neutral faces than others. So there may be a bias in how they perceive others, which then sort of snowballs and leads to all kinds of social interaction problems and feelings of emptiness. There is no specific pharmacological treatment, but so often depression is a comorbidity, so treating with antidepressants can be helpful. Sometimes a very low dose of an antipsychotic can help contain them a bit. Not that they're psychotic, but give them sort of help them hold together under stress. So, but again, there's no specific treatment, they're just strategies, but it's no replacement, medication is no replacement for the psychological treatments that are very helpful. There's a guy named Fonagy, who's now at UCLA, developed another treatment for it called mentalization treatment. There's been psychoanalytic treatments. There are many different theorists. All have shown some benefit, but I think the primary, most effective treatment is dialectical behavioral therapy.
Are there mood stabilizing drugs that relax without increasing appetite? Without increasing appetite.
So, lamotrigine, there are three first-line mood stabilizers for bipolar disorder: lithium, depakote, and lamotrigine. They have the best clinical evidence in their efficacy, and then there's second and third line. Lamotrigine is mostly weight neutral. Can't say anything's 100% weight neutral, but people have changes in appetites for all sorts of reasons. I mean, being depressed can cause you to lose your appetite or can trigger binge eating, and changing that mood can also change that dynamic. But depakote definitely can cause weight gain, lithium can cause weight gain. Most of the atypical antipsychotics, which are second or third line treatments, can cause weight gain, some far more than others. Trileptal, which doesn't have a lot of published data, but many people believe works, is mostly weight neutral. So it's a matter of degree, but never say never. Never say you're not going to gain weight with anything. Just probably won't with lamotrigine.
One question that's come up several times is, how can I help my loved one accept their mental illness and treatment?
How can I? How could that, again, that's a really general question. Dr. Amador, any of you read his books? He's a psychologist who had a brother who had schizophrenia. Developed strategies on how to communicate with a loved one who has serious mental illness, so that it comes with empathy and good boundaries and the ability and mutual respect. The hope is that you can help someone, even if they don't accept that they have mental illness, recognize that there's something that's not working in their life and try to develop a pathway to recovery. You don't have to give it a label. It's one of my daughters used to tell me, labels are for cans, not for people. Oftentimes we're talking about people who are in distress. And the American Psychiatric Association made it clear that in order for something to be seen as a treatable illness, it has to either cause distress or dysfunction. If it does not cause distress or dysfunction, then it doesn't need treatment. The world is filled with diversity. That was a big controversy around homosexuality. Finally, the American Psychiatric Association took a stand in the 1970s, said this is not a mental illness, it's just a variant on the human experience. Because what they saw was the stigma about that society had against homosexuality was causing the distress and the dysfunction, not being gay.
Is it true that Adderall has similar effects as meth?
So Adderall is a stimulant. Meth is a much more potent stimulant, and it's also about the route of administration. So again, it's Adderall in someone who has a legitimate attention deficit hyperactivity disorder, which is a developmental disorder, generally developmental problems in the prefrontal cortex in the area of executive control. You're trying to tune it to be a little bit more focused and self-regulating with low doses. People who abuse meth are taking massive quantities of stimulants that are more potent and longer lasting. So again, it's like the analogy is having a beer with lunch, the same thing as drinking a gallon of vodka. It's not the same experience.
And returning to your response to the last question, how do you include the special needs of the LGBTQ population in your sessions, in your work?
Well, I think it takes cultural competence and really understanding, individuals' lives. I don't think it's any different from anyone else in a way. It's about having deep empathy and trying to understand their lives. One of my daughters is lesbian and certainly has taught me a lot about her experience. Sorry.
Can you do a DNA test to help with prescribing or diagnosis, and how effective is that?
So there are a number of companies that have come out with gene testing that mostly they're helpful in seeing if you have variations on metabolic pathways to see how you metabolize a drug. They can be useful, they cost money. Sometimes insurance companies will pay for it, sometimes they won't. I don't think it's completely ready for prime time. I think people think that it's far more useful than it is. I have nothing against using it, but when I look at what it might cost and then the results that I get that are sometimes a little bit useful, it's not mind-blowing. I do think there is a future where genetic testing will be a critical part of what we do, but I don't think we're there yet.
We've got about 5 more minutes.
Okay. What do you see as the main reasons between a client who is successful and a client who is struggling?
Well, I think it's been said that 2 of the best predictors of success in life are persistence and good social skills. Those 2 characteristics are much more predictive of success than, say, IQ. So having a client who's persistent And part of my job is to help them have that persistence and coach them to not give up and to try to engage their families if they have a reasonable family relationship or their allies to enhance that persistence. And then social skills are something that can be taught with time. And so those are two of the factors that I think really help. I mean, some people are lucky and they respond to treatment very quickly. I think it's a weird thing, but there have been a lot of studies on likability, and the more likable you are, the more likely you're going to do better because people are more likely to want to persist with you and provide services. So trying to find a way to be likable. I don't know.
Thank you. How can I tell if my loved one is being rude or mean, or if it's symptom of mental illness? Likewise, how do I know if I'm being rude or mean, or if it's a symptom of my mental illness?
Well, it's not good to be mean or rude. If you're bipolar and you're in a manic episode and you're very irritable, which is a very core kind of symptom, it's either euphoria or irritability or both, developing an awareness that you're losing control, and that as much as possible, try to teach those around you that you're trying to gain control and to ask for some kind of compassion and tolerance while you're in a state like that. If someone's completely psychotic and delusional, I mean, that's a little easier for a family member to say, well, he's paranoid, he feels that he's being followed by the FBI, and he's getting explosive in his anger. It's part of his mental illness. But it's always good to teach compassion and to try to, that is a basic social skill. So I don't think there's a simple answer to that, but.
And then maybe two questions, I'm not sure. But one, what's better, old school or new school medications?
They're different. I think the more we have, the better. I mean, when you say old school, you're talking about medications from the 1970s or 80s versus now. I mean, in terms of treating schizophrenia, for example, the most effective drug is clozapine, but it's also one of the least tolerable. It's been around since the late 1980s. So there have not been a lot of breakthroughs with new medications. They're usually variations of what have been around before. The hope is that they would be more tolerable and easy to take. I think the one big breakthrough medication that's completely changing psychiatry is the use of ketamine or it's enantiomer, S-ketamine in treatment-resistant depression. That's completely different, and I've seen some incredible results.
Okay, and last, how can family help?
Love the family member who's the consumer of mental health services. Love, compassion, but good boundaries. There's the data on high expressed emotion in families. So if you have, it's been demonstrated in both bipolar disorder and in schizophrenia. If a family member and the client's living with you, if you have high expressed emotion in that family, it predicts a worse outcome. What is high expressed emotion? Being critical, controlling, intrusive, loud. If you can really reduce those negative stimulations, you really improve the outcome of the client.
Thank you so much.
All right. A round of applause for Dr. Cole.
Thank you.